towards approaching this disease. And most of all, I want to thank and also introduce Dr. Joyce Liao, who has, together with this amazing team, put together a second annual virtual conference here that is just really exciting in scope. Joyce is professor of ophthalmology and vice chair for academic affairs for the department, and importantly has been directing the Center for Optic Drusen since it was founded now a couple of years ago. And watching the progress get made on both clinical and research fronts with this broad international collaborating group of investigators has been absolutely inspiring, and I think a model for how we should be approaching really the research around any disease process. So anyway, with that said, I don't want to belabor any further my participation here. I will turn it over to our esteemed leader, Joyce Liao.
Thank you for that wonderful introduction, Jeff. Good morning, everybody. Hello from Palo Alto, California. I'm going to share my talk and welcome everybody. Okay. The Stanford Center for Optic Drusen was founded in 2019 thanks to a generous donation, which makes our research possible. Optic Drusen is an orphan disease, and we are determined to transform this condition and the treatment and diagnosis of optic Drusen through effort of the entire Stanford team and beyond. I'm pleased to welcome all of you to the second annual, albeit virtual, Optic Drusen meeting. And at this time, I would like to welcome people from all over the world. I know you're coming from different time zones, so I really appreciate you joining us. I would like to invite you to send a message in chat saying hi and where you're coming from. Please feel free to post freely throughout the meeting in chat, and also to ask questions through Q&A. Optic Drusen often is present in childhood, and then it evolves over time so that it becomes larger and causes vision loss. You're going to hear from Dr. Barris in session 1 more about pediatric optic Drusen, and you'll hear about adult optic Drusen throughout. Please also join us in session 3, where you'll hear patient stories. So we're really the people in the front line, both the patients as well as the physicians and scientists who are tackling this disease. Just to show you some examples, this is a patient who has one eye optic Drusen on the left side and one eye normal. The fundus color imaging shows a slightly blur, a non-specific disc margin. On autofluorescence imaging, you could see this hyper autofluorescence signal throughout the optic disc in the affected eye. And then on optical coherence tomography, you could see the relatively deep, large buried drusen in this particular side. Historically, some of the best studies in optic Drusen was done actually quite a while ago in 1981, where Mark So published this single author tour de force paper looking at histology and electron microscopy of a large number of optic Drusen. I'm showing you here a comparison, not from the same eye, but from a patient whose in vivo imaging seems to match very well with this particularly historic figure, so that you could see what it looks like on histology compared to in vivo imaging. On electron microscopy, it's thought that the calcified mitochondria in the optic Drusen optic nerves somehow, through multiple years, form larger and larger optic Drusen, causing local optic neuropathy and a vasculopathy. Dr. Hammond is going to give our first talk shortly in session 1, and he and others have published this wonderful review on optic disc drusen, and they summarize a lot of publications that show that the majority of patients with optic disc drusen actually exhibit some type of visual field loss. Dr. Yen, who will give one of the talks in session 1 as well, will discuss the changes in the vasculature as a result of optic disc drusen and vision loss. So in session 1, we have 6 speakers who will focus on diagnosis and ophthalmic imaging of optic disc drusen. Here are their pictures. In sessions 2 and 4, we're going to tackle the retinal ganglion cells and optic nerve, but just very briefly, the hypothesis on how optic disc drusen may have formed is that there is an unknown event that leads to ectopic calcification because the optic nerve is not supposed to contain calcium in the mitochondria in the way that we see on histology. So the formation of the optic disc drusen leads to more calcification and larger drusen over time, which causes an axonopathy, a glial disorder, local inflammation, vascular changes, and neurodegeneration, leading to vision loss. We think there are triggers, things that put our optic nerve at further stress, including metabolic stress, hypoxic or ischemic insult, many conditions leading to an impaired axonal transport in an optic nerve that's already crowded and at risk. We think that we can identify novel approaches to diagnose patients before they lose vision, and then work on treatment strategies. So these will be the focus of sessions 2 and 4, talking about the basic neurobiology of optic nerve and how we could tackle this in future clinical trials. So just to show you the program, session 2, pathobiology of retinal ganglion cells. We have 4 wonderful speakers, including Dr. Tatiana Jacobs from Harvard. And then in session 4, treatment trials and natural history study, we have 5 speakers plus a long panel discussion. So thank you all for joining us. Just briefly, if you want to post a message, please send a chat message to all panels. You could also raise your hand or ask questions in Q&A. We'll be sending you messages throughout the day, so please pay attention and please enjoy and ask lots of questions. At this time, I'm going to unshare my talk and introduce our first speaker and my co-moderator. Stefan, can you share? There you go. Want to welcome Dr. Stefan Hammond. He is a consultant neuro-ophthalmologist and research associate professor at University of Copenhagen at Denmark. His research centers around optic neuropathies, in particular, optic disc drusen. In 2015, he founded the International Optic Disc Drusen Studies Consortium, of which he is chair. His goal is to investigate the etiology, diagnostic principles, structure-function relationship, and management of optic disc drusen. Dr. Hammond, welcome.
Thank you very much.
His talk is entitled Optical Coherence Tomography of Optic Disc Drusen. Welcome, Stefan.
Thank you very much, Joyce, for this kind introduction and for the invitation. And I'm really looking forward to this very, very exciting program. And I'll jump straight into it and ask the question, why do we care about optic disc drusen? As you shall see, probably many times, they may mimic papilledema. Almost always, they cause progressive axonal injury and visual field defects, probably due to compression. And sometimes they may cause sudden axonal injury and visual field loss. This is usually due to AION, anterior ischemic optic neuropathy. And finally, they provide an excellent research model for studies of axonal compression and ischemia. So as Joyce also mentioned, they come in 2 flavors. Well, actually, they come in 4 flavors. But first of all, they can either be visible or they can be invisible. So when they're visible, they are usually without pseudopapilledema. And when they're buried beneath the surface, they usually look a lot like papilledema, where we call it pseudopapilledema. But actually, you can also have the combined situation where you have visible drusen, as here, and then you have pseudopapilledema at the same time. And actually, you can also get a completely normal-looking disc without pseudopapilledema, but with buried optic disc drusen. And if you want to diagnose using ophthalmoscopy, of course, this is very easy to see the drusen here. It can be easy to see the drusen here, but here you should be aware of coexisting papilledema. And in this case, it's hard because here you need to rule out papilledema. And in this case, it's actually impossible to diagnose using ophthalmoscopy. So we need another test to do this. Before I talk about OCT, I'll just mention to you that the visibility of the drusen depends very much on the age of the patient. And if you're young and adolescent, and we're going to hear more about this from Dr. Beres soon, you see a lot of visible drusen. So if you're below 10 years of age, it's almost all the drusen that are buried. And the older you get, the more visible the drusen get. And if you're above 80 years old or so, all of them are visible. So those data from our own cohort are published yet. So as I mentioned, ODD may mimic a subtle papilledema. So if you have a severe papilledema with lots of hemorrhages and cutworm spots, etc., it's easy to place this diagnosis. But when you have a subtle papilledema, it can be quite difficult. So these 2 conditions look pretty much alike. To the left, you have buried optic disc drusen, and to the right, you have idiopathic intracranial hypertension. And it can also, of course, be severe cases like in this one to the right, with an 8-year-old with a large brain tumor. It looks very much like this one to the left with buried optic disc drusen. So the question is, if we have a simple, non-invasive way to diagnose the buried optic disc drusen, and we do have, fortunately, and we use enhanced depth imaging OCT. So we want to diagnose the drusen, especially that lie beneath the surface, much like an iceberg. And we've come a long way since the first published OCT scans of drusen from Rowe and colleagues back in 1998 via the non-EDI spectral domain OCT to nowadays the enhanced depth imaging OCT. Using this modality, we can distinguish the superficial drusen from the deep drusen. Those that are superficial lie above a line connecting the 2 Brooks membrane openings on either side of the optic disc. And we can also use a little scale bar here to say whether the drusen are large, small, or conglomerates. We can actually use this modality to detect drusen in all ages, regardless of the degree of calcification. And in the International Optic Disc Drusen Studies Consortium, we've come up with some guidelines to diagnosing drusen using OCT. I'll not go through this in detail. You can see it on our website as well. Just mention to you that it's very important when we do our dense optic nerve head scan to do it with at least 97 sections in the area. The reason for this is that if you do 97 sections, you get 30 microns between each scan. And in that way, we are sure to capture all the drusen. So here is a sum up of our guidelines. The drusen, they always have a hypo-reflective core, often with a hyper-reflective margin. We often see these prelaminar hyper-reflective lines. I'll get back to this shortly. And we also often see the FARMs, the peripapillary hyper-reflective ovoid mass-like structures. So neither these or these should be counted as drusen. I'll get back to it why. And often, of course, you also see the vessels, and these are tubular in structure, and they cast shadows all the way through the disc, apart from, all right, so we can do manual volume segmentation to get these nice 3D animations of the Drusen. It is a very laborsome work. It takes a lot of time. And recently we have been working with artificial intelligence, and this is in collaboration with Associate Professor Michael Girard in Singapore, who we have provided with hundreds of EDI OCTs of papilledema and ODD cases. And then the computer has been fed with these data, and using deep learning, it can come up with these nice automatic segmentations. And if there are drusen present in the disk, it is shown up as a blue structure. As you see here to the right, you see this drusen lying nicely here, the big drusen here, and over to the left, there's no drusen. So, of course, this needs a lot of images, and we're not there yet, but I believe that this is going to be the future in diagnostics. So I mentioned these structures, the farms and the prelaminar hyperreflective lines. The farms are seen in three conditions overall. They're seen in drusen, they're seen in tilted, usually myopic optic discs, as down here, and they're seen in optic disc edema of all kinds. Up here, you see a case with papilledema before treatment and after treatment. You see the farms, it diminishes in size, and here's a case of non-arteritic anterior ischemic optic neuropathy. Here's one in CRVO, and here's one in optic neuritis before and after the attack, where you see it completely goes away. And when we started describing these structures, we actually thought that there were many of them in one particular disc, but we actually found out recently that it goes all the way around the disc, much like a donut. And here is one example where it goes all the 360 degrees around the disc. It's not always it goes all the way around. And here you can follow the forms here. It is. It pushes up the peripapillary border, giving the pseudopapilledema, and goes almost all the way around the disc. So the hyperreflective lines, we did a study where we looked at normal kids in the age of 12 years, and we looked at them again in the age of 17 years. And all of those who had drusen also had hyperreflective lines. And those that were 12 years old without drusen but had hyperreflective lines, here you could see that the hyperreflective lines progressed to drusen when they were 17 years old. And this progression to ODD support the concept that these lines are potential ODD precursors. I stress potential because it's not sure that they're going to develop into it. And we recently did a study where we looked at post-papilledema patients with IIH, who had the diagnosis at least 3 months prior, so they had no disc edema anymore. And we actually saw a very high prevalence of hyperreflexive lines in these patients. 31% of them had hyperreflexive lines. So what we conclude based on our studies is that hyperreflective lines is probably a crowding phenomenon as the forms, and it's seen in congenital crowded discs where they have the potential of developing into drusen, and it's also seen in acquired crowded discs such as in papilledema, where they persist post-papilledema but where they do not develop into so-called secondary drusen. So what about sweat source OCT? And here's the same patient who had an EDI OCT and sweat source OCT. And it looks pretty good and almost the same. So the pros are that you have a longer wavelength and higher scan speed that permit a deeper tissue visualization. And one of the very good things is that you have a combined OCTA and SSOCT, and thereby we can visualize vascular flow changes associated with ODD. And we're going to hear more about OCTA in a little while. And also volume scans of the macula provided by SSOCT and the corresponding OCTA measures of vascular density. It can also be correlated with tests of visual function. So this is very promising. It's probably a slightly inferior resolution. We're doing a study at the moment where we're comparing the two modalities. Perhaps we can optimize the SSOCT so it will be as good or even better. We don't know yet. Okay, so I just mentioned you should be aware, of course, of coexisting papilledema and buried optic disc drusen. So here you can have, of course, both things at the same time. Here you have an 18-year-old female with papilledema, and when we do the On-phos OCT, we see the peripapillary wrinkles here, and this is very characteristic of the papilledema and not seen in pseudopapilledema. This is a case from Dr. Patrick Sippen in New York, by the way. And here you see the dilated ventricular system. When we do the EDI OCT, you can see there's probably a drusen down here. It's a little difficult due to all the edema, but when we place a drain in the ventricular system and the edema goes away, you can clearly see the drusen lying down here. So how is OCT useful in a clinical setting when you are evaluating the ODD patients? As I mentioned, we always have the progressive axonal injury, and we sometimes have the sudden axonal injury. So this is the progressive axonal injury. Here, size matters. The larger the drusen gets, the more severe the visual field defect, and the more the peripapillary atrophy. So it's a clear relation here. This is just a case of an 82-year-old woman. She was actually treated for 20 years for suspected normal tension glaucoma, until one day someone performed an EDI OCT of the optic nerve head, and look here, this very, very huge drusen. So this is actually an example of buried optic disc drusen without pseudopapilledema. And just by looking at the disc, you have no chance of saying that there is drusen lying underneath. And this is another case of giant optic disc drusen, of course, with severe visual field constriction, and a few cases of sudden axonal injury. This is a 14-year-old boy who had an AION due to drusen on the right side in August last year, and unfortunately 6 weeks later he had an AION on his left side, and now you can see the optic atrophy here on the right side. And recently we just did a study here where we saw a branch retinal vein occlusion, well, not a study, a case study, precipitated by compression between this major retinal artery and the drusen here. So the take-home messages: a dense EDI OCT of the optic nerve head can be used to detect ODD in any patient, and it's well suited to distinguish between subtle papilledema and buried drusen. The FOMS and the prelaminar hyperreflective lines are crowding phenomena seen in both conditions. You should be aware of coexisting ODD and papilledema, and there are tricks to distinguish the two, as I mentioned, and the use of AI will be of great aid in the near future. This is just to show you where the members of the Optic Disc Drusen Studies Consortium are located. I apologize for this map. It's not showing the entire world. I don't know what happened, but you can see here to the right that we are spread out all over the world. So with this, thank you very much for your attention, and happy to take any questions.
Thank you for that breathtaking talk, Dr. Hammond. The Q&A and chat are both blowing up, but for the sake of time, we're going to ask a couple of questions. There's an attendee who wonders, how long does the 97 EDI scan protocol take per eye?
So if you just mean the dense optic nerve head scan and not the macular scan and peripapillary scan and all the other ones, if you just mean this one, in a well-cooperating patient, it takes about 5 minutes per eye.
And then Dr. L. Elkins asks, if optic disc drusen has already been diagnosed with other imaging, is OCT still necessary?
No, well, what you get from the OCT is like a quantitative measures. Of course, if you have diagnosed using ultrasound or autofluorescence or something, and you can say, well, there are drusen, and you're not interested in measuring the damage they have done on the retinal nerve fiber layer or the ganglion cell layer or the volume of the drusen or anything like that, it's not necessary to do the OCT. But what you get in addition to the other modalities is you get the quantitative measures.
Terrific. So for the sake of time, we're going to save some of the hot questions for the panel discussion. We'll have 20 minutes at the end of the session to address questions. Please go ahead and fill out the poll questions that's posted now, and I'm the next speaker. So I'm going to let Dr. Hammond do his thing while I share my talk.
Yes. So thank you very much, Joyce. And it is a great pleasure to introduce to you Dr. Liao. You already had a very nice introduction by Dr. Goldblum, but I'll just mention that Dr. Liao, she's dedicated to making basic discoveries and improving clinical care and treatment of patients with eye-brain issues. And as mentioned, she is the director of the Stanford Center for Optic Drusen at Byers Eye Institute. She is the vice chair of academic affairs and the director of neuro-ophthalmic services, as well as co-director of the Vision Research Training Program. So welcome, Joyce, if I can say so, and please.
Thank you so much, Stefan. I'm going to talk about On-phos imaging in optic disc drusen. This is a complement to Dr. Hammond's talk on OCT. And it will probably address some of the audience questions as well. I have no relevant commercial financial disclosure. We have 3 objectives in this talk. 1, learn what optic disc drusen look like in different On-phos ophthalmic imaging techniques. 2, know the most sensitive On-phos ophthalmic imaging technique in the diagnosis of optic disc drusen. And finally, 3, learn what optic nerve ischemia associated with optic disc drusen, also called ODD-AION, look like in On-phos imaging. The first one is on different techniques used to image optic disc drusen. So here is a right eye comparing color fundus imaging on top left with autofluorescence imaging using a confocal scanning laser ophthalmoscope versus multicolor imaging, again using C-slope, compared to a enhanced depth imaging OCT B scan. So what you can see is that they look quite different. The color image, you again see sort of this non-specific fullness and blurring of the optic disc and a lumpy, bumpy appearance. On autofluorescence imaging, you see quite a bit more texture. So drusen of different sizes, some are quite large in the nasal portion of the optic disc, and some are tiny and relatively superficial. On multicolor imaging, you could see some of the shine through, which is visible on the near infrared reflectance component of the multicolor imaging. On the B scan, which is a slice through part of the optic disc, which is illustrated here, you see the little clusters. There's actually quite a few. They're all in different depths. Some are quite small, some are a little larger, medium size, and then there's a relatively large one here that's visible in the nasal quadrant. So they look quite different, but they are all showing different aspects of the drusen. On confocal scanning laser ophthalmoscope, if you look at the color versus autofluorescence imaging, you can see that this looks, the autofluorescence imaging provides much more texture compared to the traditional color imaging. If you then look at the On-phos imaging, what you see is that it's a natural view of the optic nerve during a clinical exam. So when we look at it, we could tell immediately in one image whether there is a lot of drusen on the nasal quadrant as well as the other quadrants, and whether there are vascular changes, which is visible on the color image here, and also visible on other aspects of phos imaging. Finally, this is actually already done as part of just screening for optic nerve pathology, such as the question earlier by the audience, Dr. Altman, looking at using the OptoMap instrument. Number two, which On-phos imaging modality is the most sensitive in the diagnosis of optic disc drusen? To answer this question, we perform a retrospective single center study. We search for the diagnostic code for optic disc drusen, or use the words optic disc drusen in natural language processing, and identify 786 patients in the Stanford database. Of these, 497 has some type of ophthalmic imaging, specifically the modern fundus imaging or OCT scan. Of these, 156 were reviewed and found to have multiple imaging modalities performed, including color autofluorescence imaging or OCT. We then identify using the enhanced depth imaging, using OCT as the gold standard to confirm the presence of optic disc drusen, and then compare the On-phos imaging modalities, color fundus imaging, autofluorescent imaging, and near-infrared reflectance, which is acquired as part of the OCT imaging. Overall, we looked at 38 subjects with 61 eyes, of which 23 were bilateral and 15 were unilateral. Here are 4 examples of what the images look like on green versus blue light autofluorescence imaging versus near infrared reflectance imaging. So what you can see from top to bottom is the amount of brightness in the green light autofluorescence imaging. So the top row, this eye has a lot of drusen. It fills the entire disc. The second row is primarily the nasal quadrant. Third row, it's also more diffuse. And then on the fourth row, there's no visible green autofluorescence. If you compare the green versus blue, what you see is that there's a lot more texture and variability or heterogeneity of the signal, the hyperfluorescent signal. And we believe that the short wavelength of the blue light, it has a shallower penetration, and so that the superficial drusen are brighter, while the deep drusen are relatively darker. So comparing the green versus blue, you could get a sense of the depth of the drusen and where they're located. You could also look at the near infrared reflectance, which we'll come back to in a moment. So if you look at the berry drusen on the last case, where there's no visible autofluorescence imaging on the green or the blue autofluorescence, you could actually see that there is a deep drusen in the below the Bruch's membrane opening. And this is one case where you really needed to do the enhanced depth imaging in order to see it. We compared the near infrared reflectance in drusen versus OCT, and there's some quite interesting features. So like I said, this is acquired as part of the enhanced depth imaging protocol as a localizing image, but you should not just dismiss it as a localizer. There's actually some very interesting features. So a normal optic disc would look black on near infrared reflectance imaging, but in the eyes with optic disc drusen, you could see little pearls on the top row, or bubble looking structure on the bottom row. If you compare across, what you'll see is there's some very small, super bright dots. And this on a detailed comparison correspond to hyperreflective lines on the OCT scan. If you look at this one, there's a bright spot at the sort of 5 o'clock position on this optic disc. And that corresponds with this hyperreflective line, seemingly 2 lines with a tiny drusen in the middle. When we compare all the different modalities, we see that the green light autofluorescence imaging is the most sensitive in terms of the On-phos imaging modality and correctly diagnose 97% of all optic disc drusen using the EDI OCT as the gold standard. The blue light autofluorescence and near infrared reflectance and color imaging are in subsequent orders in terms of diagnostic sensitivity. So lastly, quickly, what does the On-phos imaging look like in acute ischemic optic neuropathy? As Dr. Hammond mentioned, ischemic optic neuropathy is the most common severe acute way that vision is lost in patients with optic disc drusen. And this is thought to be due to the impact of drusen on the vasculature and possibly as well as compression of the unmyelinated optic nerve head. So this is a woman who had incidental finding of optic disc drusen when she presented for vision evaluation. Her visual acuity is 20/20 in both eyes, and she has visible optic disc drusen on this color imaging. And you can see some that are quite superficial in both eyes. She has some mild patchy inferior visual field defect, which correspond with a more localized superior location of the more superficial drusen and thinning on the optical coherence tomography retinal nerve fiber layer analysis. 2 years later, she noted new onset blurry vision in the left eye. So this is her previous visual field test. And then this is the new one that shows a new inferior altitudinal type visual field defect. And if you look at the color imaging, you see that there is hemorrhage in the superior portion of the optic disc more than the inferior. And there is just this blurring, almost like a little volcano rising with the lava flowing outwards, that feeling. If you look at the ischemic optic neuropathy associated with optic disc drusen compared to the regular ischemic optic neuropathy without optic disc drusen, you see that there is this raised three-dimensional structure with some exposed drusen underneath it. So this is a busy slide, but you're welcome to look at the publication, which we'll share the link after this talk. Essentially, if you look at the acute ischemia versus the baseline, again, on the near infrared reflectance imaging, you see this blurring and lava flowing like appearance on near infrared reflectance and a little bit of a decrease or blocking of the autofluorescence imaging. If you then compare that with a regular AION without optic disc drusen, what you see is that the optic disc is completely black in the case because there's no drusen there, and the nerve has a less of a three-dimensional appearance. Then if you compare baseline versus acute ischemia versus chronic, you see this progression from swelling in the acute phase to thinning and pallor as a result of the ischemia and a persistence of the visual field defect, unfortunately. So I'm going to skip this slide. So in summary, high-resolution On-phos imaging is routinely and rapidly performed in the busy eye clinic and can provide some information on the size and depth of optic disc drusen. The C-slow green light autofluorescence imaging is the most sensitive On-phos diagnostic imaging method, but the gold standard is still enhanced depth imaging OCT. Optic nerve ischemia is the most common cause of acute vision loss in optic disc drusen. And as Dr. Hammond pointed to, it's important to compare the edematous or full-looking optic nerve in the setting of optic disc drusen to distinguish ischemia versus edema or papilledema using ophthalmic imaging. Thank you.
Thank you very much, Joyce. What a beautiful talk. Let me see if we have got any questions in the Q&A here. Yes, there's one question here. The woman with ODD-associated NIA, there seems to be significant circumpapillary subretinal hemorrhage. Was a fluorescein angiography done? And it's from Leonard Levine. And he's wondering if there was a SRN VM.
Good question. At that time, we actually did not do the fluorescein angiography, primarily because the patient was actually quite anxious and tearful. So we focused the clinical visit on just the things that we had to do. The neovascular membrane is a good question, and absolutely, the fluorescein angiography is the gold standard for diagnosing that. And Dr. Diana Doe will be giving a talk on that shortly at the end of this session.
Great. Another question is from Scott Foreman. Is On-phos B-scan OCT imaging a software package with the OCT?
So there are multimodal commercial imaging systems where you could perform the enhanced depth imaging along with the blue autofluorescence imaging, for example. There is no analysis package, although some of the manufacturers claim that there are ways of doing quantitative or semi-quantitative autofluorescent imaging if you follow their directions. But in general, I think the beauty of using a multimodal system is that you could obtain different modalities, which helps you to be able to compare patients as they move on over time.
Great. And we'll have one last question, Joyce, and then I think we'll have to move on. And it's actually a very hard question. I don't know if you're able to answer this. What would be the treatment for AION associated with ODD?
Yeah, that's really the question. So as some of you know, there is no FDA-approved drug as treatment for anterior ischemic optic neuropathy of any type. The goal of treatment is to do our best to address every single risk factor and to prevent further vision loss in hope that maybe some visual recovery is possible, as published in a large series by Hey Ray. So I think that question is what's inspiring us to do a lot of our research currently, and I hope to be able to bring you some of these answers in the future. I'm definitely looking forward to discussing how we could do it in the next sessions.
Okay. Thank you very much, Joyce. And will you introduce the next speaker?